Welcome, and thank you all for joining us today for the AHRMM webinar, Ethylene Oxide Device Sterilization and the Alternatives. I am Brian Bartell, Materials Manager at Willamette Valley Medical Center and a member of the AHRMM Education Committee. I will be moderating today's session. All lines have been placed in a listen-only mode, but you can ask questions by typing them in the Q&A box. The Q&A box can be opened by hovering your mouse at the bottom of the WebEx browser, clicking the ellipses icon, the one with the 3 dots, and clicking Q&A. The Q&A discussion will be held at the end of the session. After the session, please complete the presentation evaluation so AHRMM can improve our education for you and other healthcare supply chain professionals. You will receive your continuing education certificate about 2 weeks after you complete the survey. After today's session, you will be able to discuss the history of ethylene oxide, alternatives to ethylene oxide, and lead a discussion regarding sterilization. Switching to alternative sterilization methods can improve the quality of patient care and staff safety, which may improve patient and employee satisfaction ratings. We are thrilled to welcome today's speaker, Dr. Lena Shahbandar, a physician specializing in physical medicine and rehabilitation and is the Department Chair of Physiatry at DuPage Medical Group. She became interested in the issue of sterilization with ethylene oxide in 2018 with a local report of high cancer risks in Willowbrook, Illinois. She subsequently began to research sterilization methods and alternatives to ethylene oxide and published an article on this topic in the winter of 2018. Since then, she has been working with other scientists in her local community to understand options around sterilization of medical equipment and supplies. Our second speaker, Dr. Peter Orris, is a professor of environmental and occupational health science in the University of Illinois School of Public Health and Chief of Occupational and Environmental Medicine at the UIC Hospital and Health Sciences System. Dr. Orris has served as an advisor to WHO, PAHO, as well as federal, state, and local governments, environmental organizations, labor unions, and corporations. Dr. Shahbandar and Dr. Orris, we appreciate your time to share your expertise on sterilization practices today. I will now turn the presentation over to Dr. Orris. Dr. Orris, the floor is yours.
Thank you. Good afternoon, just about. Ethylene oxide has a variety of different synonyms that are used in different settings, and you see a listing of them there. Interesting chemical, not particularly complex, and quite directed in its usage. Next slide, please. So most ethylene oxide is used to produce materials such as ethylene glycol for automobiles and internal combustion engines, and it is produced in an entirely closed system. It's a colorless gas at room temperature and normal pressure. After the production process for most of the usages of ethylene oxide, it is a liquid in most settings. It is a liquid with an ether-like odor when it's cooled or at high pressure. It has a high odor threshold, and that is that you're probably not going to smell it until you get into the hundreds of parts per million. It's extremely flammable, and it is reactive at room temperature, and this is one of the general problems with ethylene oxide. For whatever its industrial usage, it has a tendency to explode. It is persistent in the atmosphere for 30 to 60 days, and depending on the temperature and a variety of other components. Let me give the floor to Dr. Shahbandar.
Hi, everyone. Good afternoon. I'm going to share a little bit about the history of ethylene oxide. And it's interesting, if you look back historically, we're talking about 100 years of use. Commercially, it was started to be used in the 1920s and originally in agriculture. More recently, and the part that is relevant to us is that it's become used in medical sterilization, and mainly because of its ability to sterilize things that would otherwise be destroyed by heat. So it can sterilize things at room temperature. It's been known to have mutagenic and carcinogenic properties since the mid-20th century. So original publications on this really date back to the 1950s and 60s. Originally, when it was being used in medical sterilization, it was originally being combined with chlorofluorocarbons in a mixture to mitigate against the cancer and mutagenic risk. Next slide. So what happened that became notable for us in our current situation is that the Clean Air Act was passed. And when it was passed, the goal was to help fight against air pollution and the depletion of the ozone layer. That was followed by the Montreal Protocol, which was an international movement supported by the UN to do the same thing globally. So the impact was that after this happened, ethylene oxide was now going to become a single-use sterilant, so it was no longer mixed with the chlorofluorocarbons. So you had 100% ethylene oxide, and while that was better for the depletion of the ozone layer, that resulted in an increase in flammability and toxicity of the sterilant. And so that becomes relevant then as we discuss later how the world starts looking at it as a carcinogen. In the U.S., the EPA classified that in 2016 as a Class 1 carcinogen.
Ethylene oxide works as a direct alkylating agent that disrupts DNA. So it is one of those carcinogens that has direct genotoxic impact, and therefore is one of those carcinogens that we cannot define a no effect level over a period of time for human beings, animals, or the impact. This is one of the reasons ethylene oxide is as effective as it is in its approach to sterilization, and that is that it's quite effective at the cellular level. Next slide, please. Ethylene oxide is used because it can be used in a variety of different devices. When I originally was called as a NIOSH regional medical officer back in the 1980s to respond to some of the symptoms related to ethylene oxide sterilization in healthcare facilities, we were looking primarily at desktop small units, sort of the size of a microwave, that were being used rather ubiquitously in pulmonary medicine departments around the Midwest, where I was, and the country as a whole. These since have passed out of use for a variety of reasons, among which they did not seem to be able to be constructed simply due to the pressures so that they didn't leak within those offices. The sizes that are being used now, though many hospitals are moving away from them, you see on the right side of your slide here, and that is these are the kind of sterilization devices using ethylene oxide that you may see in a central supply setting in a hospital or outside of an OR, et cetera, primarily to sterilize pieces that, for one reason or another, have become contaminated after delivery from the pre-hospital sterilization, which I call your attention now to the one on the left, and that is that most of the supplies needing ethylene oxide for sterilization, and that is pretty much anything that's not metal, the metals obviously can be used in an autoclave with pressure and steam, but the plastics of various sorts have been sterilized by ethylene oxide, and it has been done on an industrial basis, primarily in these kind of units on the left, where you put whole pallets into these units, and they then are sterilized. So devices that are being sterilized this way are delicate devices, sensitive to moisture or high temperatures. It offers process flexibility, adjustable parameters for load and device challenges, penetration through multiple layers of multiple different kinds of packaging, cartons and pallets, versus individual packages and a variety of different kinds of materials, paper, plastics, cellophane, if you will, and even cloth, which is why it is used so frequently for the OR packages, which have many different types of materials in there. You can put, these are large capacities facilities. They can be done prior to coming to the hospital, and it's understood the regulatory expectations due to the long history of use, etc. What's missing from this list is what is missing from often our planning for industrial chemicals in general, and that is this list is obviously constructed by chemical engineers and production engineers, or product engineers, if you will, and leaves out the question of what is the toxic impact on workers or communities within that process. And that's what we're trying to introduce now to the current thinking. All yours.
So this slide, I think I'm not asking everybody to look at all the details because there's a lot of information on this chart, but it's super important because when we think about how did we get to where we are, what we have to consider is what was the easiest way out, right? So if you look at the top row, you'll see that these are all different ways of sterilizing things in the more traditional world. And so you had like autoclave and dry heat and ethylene oxide and gamma radiation electron beam. And we're going to go through those in more detail later. But I want you to look on the first column. You'll see all the different kind of plastics, right? All the different polymers. And there's so many. And there were actually, this chart is a 2-page chart, but I'm just giving you a sample of it so you can see the impact. And if you go over to the column that says ethylene oxide, you see if you look down, it says basically it's a good sterilizer for almost every single category. Whereas if you look in other categories, you'll see that some things are good, other things are fair, others are poor. So what happens is naturally, without thinking, if we're not thinking that it's a major problem or a risk to the society, it's easy to just say, okay, well, we'll just sterilize everything with ethylene oxide. That doesn't mean that these plastics don't have alternatives. It just means that it's easier to not worry about what kind of plastic do I have in this package and which item can be sterilized best with this. So that's how we get to this place when we're talking about plastics. And really, plastics and disposables are our biggest problem in this whole discussion. Next slide. Okay, so generally when we're thinking about this question of impact, what is important to understand is, as Dr. Orris mentioned, the properties of ethylene oxide and that it's used in low temperature products. It is currently used in above 50% of sterilization of these non-metallic medical devices. So we're talking about a huge portion, though we're not talking about everything. And when we think about what are those products and how are they used, so there's ethylene oxide used within a hospital. So meaning in the hospitals, we have an ethylene oxide chamber and it's being used to sterilize equipment. And as we'll discuss later, there's really been a trend away from this for a long time. And part of that is the aeration process is so long. Like when you're done sterilizing, the item has to stay inside this chamber for 24 hours to get properly aerated before you get it out. So turnover time really stinks with ethylene oxide, and that's a downside about it. What is the major use, and the thing that we find is going to be our largest challenge, is the commercially sterilized items. So, you know, we use companies like Sterigenics and Willowbrook or Medline up north of Chicago and all over the country. And these companies will sterilize a whole bunch of things for us, and then they deliver them to us in the hospital settings, and then, you know, purchased by hospitals and clinics to be used. And those are where this volume and risk issue becomes really a big problem. Occupational risk, and we'll discuss this further, it's both an irritant, so an acute irritant if you're sitting around ethylene oxide in the acute phase. It's a toxin to the central and peripheral nervous system. It's a carcinogen, so it causes cancer, and it's a mutagen, so it causes mutations. And so then the final thing, and this is something we'll talk about more later, is that when we sterilize something with ethylene oxide, there is a residual amount of ethylene oxide that sits on the thing that we sterilized. And then that, when it gets opened, when that package gets opened, either the patient or the healthcare worker is exposed to a risk of this residual, and we don't have any. We have data on residuals, but we don't have any data that tells us what does that mean. So if a healthcare worker is opening these packages over and over and over, or a patient is using something that has been sterilized by ethylene oxide, what is the impact on a person there? And we don't know that information. Next slide.
I'm sorry. Interestingly enough, as we indicated before, the environmental half-life of ethylene oxide is a month to 2 months, if you will. But the physiologic half-life in the human body is much more rapid. In an hour, in general, it's gone. It's completely eliminated in 1 to 2 days. Or in an hour, it's the half-life, half of it's gone, and it's completely eliminated in 1 or 2 days. The body itself makes some component, some amount of ethylene oxide on its own, mostly from inhaling ethylene in the atmosphere, which today is a much more ubiquitous exposure in communities than it has been in the past because of its industrial use. Next slide, please. It is, as we indicated before, one of these carcinogens that has no threshold, and that is, has a toxic biologic effect, theoretically down to 0, but in fact, that's very hard to measure. So the EPA is therefore unable to identify for communities safe and unsafe levels. For toxins that have threshold, frequently the EPA is able to say above the reference dose or the reference concentration of the amount in the air is when you will begin to see effects in the population, and below the reference concentration, it would be highly unlikely to see an effect. That's for non-carcinogenic endpoints. For carcinogenic endpoints, some carcinogens work in a different mechanism, but most known human carcinogens work with the mechanism that we're talking about here, and that is they're genotoxic at the cellular level. With that mechanism, all the EPA and NIOSH and the World Health Organization and governmental agencies are able to do with respect to identifying risk related to exposure is to do a dose response curve and let the communities understand the more the exposure in general, the more the risk, and the less the exposure, the less the risk. And the target for the EPA with respect to community exposure to carcinogens is 1 extra cancer per million people as a background level, as a target for cleanup on the FDA from the EPA, 1 to 10 to the 6th. The variability of when a cleanup is triggered is higher than that, and it has to do with non-health issues such as cost, such as budget of the agencies, such as the difficulty of identifying the polluter, etc. And you can see on the left here where ethylene oxide fits as a carcinogen within the spectrum of dioxins. That's the old Agent Orange from the Vietnam era, straight through the question of trichloroethylene of such interest today in different settings as well. And the EPA does this by standardizing what they call the inhalation unit risk, IUR, and that is derived from the slope of the dose response curve that is identified in the medical literature. And then you extrapolate that down. You include a uncertainty estimate, not a safety level, but an uncertainty estimate, and you arrive at a goal of a dose that will be per microgram per meter cube that will keep the community cancer rate less than 1 in a million extra cancers. Next slide, please.
So now talking about what are the studies that we know that showed cancer mortality. The studies that have been done on cancer mortality were done on workers, so people who work in sterilization factories and stuff like that, so that we can see what happened. And so there are a few studies. This one, this cancer mortality study, was done between 1987 and 1998. So it was a long follow-up, and it was a cohort of over 18,000 people, men and women, and 14 different commercial sterilization facilities. What they found was increased death, so mortality from lymphoid cancers, so the blood-based cancers in men, and there was a dose-response correlation. So what does that mean? That means that if you were exposed, the more you were exposed, the more likely you were to die from this kind of cancer. In women, there was increased mortality from breast cancer. And again, this was in the highest cumulative risk exposure group. So this is for the people who were most exposed. And so their ratios were pretty concerning. This is, a study that was published in 2004. So the work done on this was over, 2 decades before the publication of the study happened. And this is why it's hard to study, cancer outcomes, because you're talking about a generation of people who are born and dead from the time you're able to begin studying it until the time you're able to publish it. And I think it's important for us to think about when we're considering choices that we have now. Next slide. So between 1984 and 2008, it was considered to be a probable carcinogen. So it was likely to cause cancer. Well, these publications came out, other publications came out too, and then it was, in 2008, it was designated a known carcinogen to humans. So the evidence in humans is not completely sufficient. It's limited evidence for this causal association, so meaning it causes it directly for lymph and blood cancers and for breast cancer. In animals, the studies have been much more compelling, and obviously with animals, there's more leeway with how that experiment can be run. And so in animals, we have sufficient evidence for the carcinogenicity of ethylene oxide. Next slide.
And what's interesting with respect to this history, for those of us who've been involved and concerned about ethylene oxide in healthcare settings for some years now, was our total concern was focused on the workers in the institutions, both the neurologic findings, because workers were having neurologic effects, both central nervous system, peripheral nervous system, as well as the chronic possibilities of cancer. But we did not look at communities, and nobody really paid any attention to communities until this event in 2018, where several different pieces of information came together and called everybody's attention to the exposures in the communities. One of the pieces of events that I've already described to you was the fact that this moved from a probable carcinogen to a known carcinogen, and therefore the EPA applied that IUR estimate with respect to the risk related to ethylene oxide. At the same time that was going on, and parenthetically, that took the EPA about 10 years to do, with two external peer reviews of the document, which finally came out in 2016. And this was based on the evidence that was already described from 2004 from WHO's International Agency for Research on Cancer, reclassifying ethylene oxide, as you've heard, in 2008. And then till 2016, EPA considered this matter and then published and reevaluated this. At the same time, the EPA has a separately functioning an independently functioning, if you will, activity that the Congress mandated some years ago with respect to national air toxics. And it goes every several years. It reports on the situation with air toxics nationwide, and as a corollary of that, and part of that NATA report, it tells us which areas, often census tracts or zip codes, have what level of carcinogenic risk attached to them, and that is based upon this IUR approach to carcinogens based on a data bank from the toxic release inventories in which companies are required to report to the federal government both expected releases of toxic materials and unexpected releases. There's no supervision of that, though, so the suspicion is that that is probably underestimated in the amount. Well, the EPA released in 2018 in the summer a report based on the NATA data from 2014, and the results now showed that there were a significant number of census tracts, 109, which were exceeding agency guidelines for cancer risk, and ethylene oxide was a chief responsible in nearly all of those communities. It was the leading cause in about 39 of them, I believe. Next slide, please. So this immediately, for the first time, alerted both the public and the EPA and health scientists that there was a significant risk in communities in and around mostly these industrial plants. These were not per se clustered around hospitals still using ethylene oxide. And we estimate in Illinois there's probably about 10% of hospitals that still may have ethylene oxide internally, but none of the concern was focused in that area. Among the reasons for this were, as you look here on the TRI release inventory from Sterilization in western, just west of Chicago, you will see that up to 1998, Sterilization was releasing some 32,000 pounds in that area a year of ethylene oxide into what is a residential community within blocks of the facility itself. This was cut by 10-fold when the regulations related to this required cutting it down, and then you can see the releases in the 2000s. But if you come to the 2016 releases, this is still several thousand parts, if you will, into the atmosphere. That's the 5,000 on the left, and this was, I believe, about 3,000 parts. And so therefore, that was a 10-fold release. One of the things that ethylene oxide felt so bewildered by was they said we were obeying all of the federal and state regs with respect to this, which, looking at that, in fact, was correct. On the other hand, that was based on the old science where we didn't know the potential toxicity of ethylene oxide in this situation. Next slide, please.
Sorry about that. So what happened then was in May of last year, the EPA went around the Willowbrook area, Willowbrook, Illinois, where Sterigenics is, and collected air samples. They collected it in different commercial locations and residential locations. What was so kind of interesting about this particular factory is that the factory is not even a block away from the local Target and about a mile away from a local high school and a local middle and elementary school. So, you know, you have huge concentrations of population right around the area of the factory. So they they went around, they collected air samples, and they found a gradient of air of elevated levels of ethylene oxide right around the Sterigenics facility, and then it would get less and less the further away you got from Sterigenics. And those values were all significantly elevated compared to, again, we know that it's an adduct, so there's no safe level of ethylene oxide in the air, but the levels were significantly higher than they were outside, miles away from the facility. And so what they ultimately were able to demonstrate is that this cancer risk based on ethylene oxide levels near Sterigenics are significant. So the residents who are living 24/7 in the area of this factory of Sterigenics, if you look at this graph, you'll see that you have the cancer ranges of acceptable cancer risk range pre-2016, and you can see that was the first line. That's further out to the right than it is later, once we establish, oh my gosh, ethylene oxide is 50 times more toxic than we thought it was. So this bar graph shifts over, and so the cancer risk evaluation guideline is this blue X. Okay, so that's where it's like anything above that, we're not happy about. You see the green bars are where the risk is for people who in the residential area near Sterigenics, and then the commercial area near Sterigenics. The commercial area near Sterigenics Sterigenics is across the street from the town hall of this town of Willowbrook. So this risk is a order of magnitude of hundreds greater than what the risk evaluation guideline accepted. But it's also smaller than the risk seen in the cancer in the workers who in the animal studies and the people who worked in these areas. So you can see on this curve, it's a log curve, so it actually doesn't, it's not like a linear line like it looks on this, but the risk in the community is higher than acceptable, not as high as it is for workers.
As an underline, what that meant was it's 100 times or so more than what we looked for in the background population of 1 in a million, several hundred times more. So that was startling, and startled the community, of course, as well as the rest of us that had thought we were focusing on the problems in their full extent on ethylene oxide. In fact, when you calculated it for breast cancer, it adds to the lifetime risk a small amount, but this, of course, begs the question always of when is a little more just too much because of all the other exposures we have, or when it is a little more is not significant. And that, of course, has to do with where you're living frequently and what are the other priorities that you have besides the health implications of exposures, such as profit or building highways or other budgetary matters that come into public estimates of what we will do next based on risk. So here you see the lifetime increase in breast cancer as well as the lifetime increase. And this is all based on a 35-year exposure, which is half of the full lifetime, but you still get the same approximation. Usually we use 70-year lifespan for the estimation of risk here, and this is the risk involved. Next slide, please. So the FDA looked at this and was increasingly concerned, as all of the rest of us were and the EPA was, and there was a great deal of discussion about what can be done, how to move ahead. Their concern were twofold. Their concern was, one, we are unable to maintain the supply of sterile devices for necessary medical use if all of these industrial ethylene oxide plants are shut. So that's a concern. How do you continue to supply what is necessary and sterilize and transition from these kinds of exposures. And on the other side was you don't want to keep poisoning your local communities because you're doing such a great job taking care of individuals within, our highly technologic hospitals now, et cetera. We want to find a way of not poisoning the communities and still taking care of the patients in an adequate way, et cetera. And therefore, the FDA looked at alternatives. And one of the questions is that this did not happen earlier, as I think we've explained, because ethylene oxide was such a good chemical for what it was designed for when you didn't factor in the human health impacts. And now we can talk some about the procedures that was done on. And let me turn it over to you, Lena.
So the alternatives to ethylene oxide, I just have them listed here. And we have hydrogen peroxide vapor or plasma. So hydrogen peroxide can come in different forms. Peracetic acid, gamma radiation, E-beam, nitrogen dioxide, and chlorine dioxide. Next slide. So if we look at each of these, each of them have advantages and disadvantages. And so this is how we start to get into this, question of detail, and you start to see how, as a community at large, we're going to have to think about what are we sterilizing, where are we sterilizing, how are we sterilizing, and really pushing our industry components to help us in this way. So hydrogen peroxide vapor or plasma, it's great because it's safe for the environment, for the worker. Processing times, as I mentioned before, with ethylene oxide are very high. And so with hydrogen peroxide, they're much shorter, and there's no toxic residue. So we don't have to worry about, the residual that's sitting on these sterile gloves is impacting our healthcare workers. It can be used for heat and moisture-sensitive items. Now, the problem is with metals, it has some material incompatibility. It can cause eye damage with contact, and it can't be used for cellulose like linen and paper. So here's where you have the item can be sterilized, but maybe the packaging that it comes in can't be. And so these are where we're going to have to get creative with packaging. The next one, peracetic acid. It has environmentally friendly byproducts, and it's safe to workers. And it also has the same types of issues that hydrogen peroxide has. It is not all materials can be used, and it's immersed. So it's, the instruments have to get immersed into it. It's not a gas that permeates everything. Then we have gamma radiation. Gamma radiation has a 60-year history. It's been around a long time. It doesn't have any emissions, so that's good. And whatever gets put in, it's a product like how ethylene oxide is, where you stick a pellet inside the chamber and the entire volume of product is sterilized. And you don't need gas permeable packaging, so those are all really nice advantages of gamma radiation. But it doesn't work for all plastics or tissue allografts. So it does have some harmful changes depending on the plastic. So it's just not perfect in every category. There is some question that we don't know about is it safe to consume food that's been irradiated? And then that, brings us with the question of this risk with healthcare devices. But as far as we can see so far, it doesn't have the same harm. And then it does require requalifications annually. So it's a little bit more work, a little bit more upkeep. E-beam. E-beam is a 60-year history as well, doesn't have harmful emissions, and it doesn't use as much product in the irradiator that gamma does, and it has a very fast processing time. So those two are kind of in the same category, gamma and E-beam, just like hydrogen peroxide and peracetic acid are similar. But it has some compatibility with certain products as well. Nitrogen dioxide. Nitrogen dioxide is a newer one. It readily penetrates packaging and complex geometries, so some of the questions of long tubing and things like that that we use ethylene oxide for. It's non-toxic, non-carcinogenic in terms of the residuals, and the processing time is way lower than it is for ethylene oxide. it doesn't have perfect compatibility with every plastic, and it's not fully available. Chlorine dioxide is a pure gas. It's non-carcinogenic. It has a very quick aeration, and its compatibility is pretty strong. It's one of the stronger compatibilities to ethylene oxide. It doesn't require a whole new system. It's kind of like a trade-off. The issues with this one is that the chlorine dioxide has to be produced on site. You can't just get chlorine dioxide from another place, bring it to your sterilization facility, and plug and play because it's difficult to transport. The main issue with it is that it is explosive under pressure. So as long as you make it there, it's fine, but if you don't, there are big risks with it. So as you can see, none of the alternatives are perfect. All of them have advantages and disadvantages. Next slide.
So as we've mentioned to this point, many hospitals over the last couple of decades have shifted away from ethylene oxide sterilization in central supply, in pulmonary departments, and around for the OR. Many of these hospitals have changed to hydrogen peroxide because it is well suited for these small sterilization devices, maybe the size of a refrigerator, and are non-carcinogenic to the degree that we understand today. And they are usable because most of the time, what they are sterilizing with in the hospital and central supply is in fact one device, one supply that has for some reason become contaminated, or they are redoing some individual different pieces. And so it is not like what Medline does, and that is prepare a whole OR pack with a variety of different materials in it. So it's an easier process, and with hydrogen peroxide in-house or peracetic acid treated in certain ways to be a gas and useful in this setting. And as you see, many of the leaders in, if you will, greening the hospital system, such as Kaiser and Hitchcock up in New Hampshire, we're also leading with respect to moving away from this. But for instance, as I mentioned earlier, in Illinois, the best guess is that less than 10% of the hospitals still have ethylene oxide in-house. That doesn't mean they're not getting much of their materials from industrial sterilization. Next slide, please. All right, so the FDA then looks at this situation, and let's talk just a minute before it begins to intervene to figure out how to move us as a whole, and that is, what's the process for approval? Because when this issue was first raised with Stereogenics, they said, this is the only material, ethylene oxide, that's approved by the FDA for whole numbers of different materials that are used in these settings. And that was true, but not true. It was true because it was the only one approved, but the process by which the FDA was handling approvals for sterilants over the last 50 years is one in which the supplier, Johnson & Johnson, or a variety of other suppliers, come up with a new device and they want to market it, and they come to their sterilization engineers and they say, we need a process that effectively sterilizes this device. That's a 6-log drop in organisms, and we want to put this on the market. So clearly within the dynamic, and then sometimes they even contract the experimenting on this to one of the companies such as Stereogenics. So they may do it jointly, or Medline does a lot of these because they have a laboratory specifically set up to identify how good these different methods are for sterilization. Having said that, they give it to them, and the engineer, and they tell the engineer, come up with the best method of doing this, and please do it quickly because we'd like to get to market. So the testing is done in-house, and then those reports are provided to the FDA. And so what the FDA then does, it reviews those reports and says, that's adequate, you got a 6-log draft, so we're going to approve this process of sterilization for this particular supply. I've been told there's some 60,000 different different types of products out there. So there are many, many different approvals here. It would extend that process some number of months to start with something that is not ethylene oxide, or to get a secondary approval for hydrogen peroxide or E-beam or whatever. Still, many things, because there are companies now that are primarily doing these other alternatives, there are many things that are double approved, but still the vast majority is approved for ethylene oxide alone. And that's the answer there about why that is occurring. And what we would like to do, as well as the FDA, is to move this to say, when you are purchasing supplies, and they tell you these are first to ask what is the sterilant being used, and then secondarily say, can we use something else besides ethylene oxide? This will stimulate the producers to experiment as well with alternatives so that they maintain the market. In order to stimulate this, there are also engineering innovations that are necessary, both to reduce the amount of ethylene oxide in use as they are now using it, and these are possible, as well as shifting to other materials for sterilization. And the FDA is now responding to 46 applications. They've approved 12 of them so far for creative methods of shifting away from ethylene oxide and reducing the amount necessary at the same time. And it is hoped that over a period of time, we will be able to shift the market away from this use. The shifting has both technical challenges, engineering challenges, and others, which are too long and specific to get into on this point. And they also have some capacity challenges. So this is a process that will take months to a period of years. Next slide. One last thing I should just
yes, go ahead and say that.
There was an excellent 2-day seminar held in Maryland by the FDA this past month, November 6th and 7th. It was a seminar it was a hearing rather, that was conducted by the FDA's advisory panel on sterilization in the hospitals and materials, and it was really just excellent and encyclopedic in terms of our current status with respect to that. It had some FDA reports, but it also allowed time for many different elements within the industry to talk about how they were doing sterilization, etc. So one thing is, on this webpage, you can secure most of the slides and the FDA's conclusions, the panel's conclusions, with respect to these methodologies and the estimates of the capacity. But then at the bottom of that list, you also have a transcript of the entire 2-day process. And it's quite a text for the current status because everybody had a chance to speak. And I urge anybody interested in the area to download that into a PDF and then use your Control F to search under that for various things. Thank you. Dr. Shahbandar, all yours.
So lastly, as, when I think about this from the perspective of a hospital, we need to push industry to adopt newer alternatives for these high-volume sterilization of disposables. So again, you're thinking about it, most of the hospitals are okay, and if you're not, get okay with not using ethylene oxide in-house, because that's got precedent in front of it. We can follow those. Those are easy to do. the next step is how do we not buy materials that have been sterilized with ethylene oxide? And we need to really push the commercial organizations, the commercial companies. Now, what's interesting is, like, for instance, Steris does commercial sterilization with ethylene oxide, but Steris, which is different than Sterigenics, also uses parasitic acid and hydrogen peroxide, and is one of the companies that sells the smaller units to the hospitals to use the hydrogen peroxide. So, you know, the question then becomes to Steris, well, you sell us the hydrogen peroxide chamber, why don't you make this commercial size so you can do this in other facilities and bring it, then we can buy it from you. So we need to push them to do these things. The other side of this is, as hospitals, we're responsible for the care of our workers, and to think that now we have documented evidence of the risk to the people who work in the sterilization factories. And we know there's documented evidence, multiple hundreds of risk over normal for people who live in the communities where these commercial sterilization facilities are. You know, we don't have any documentation on the impact of these residuals that we know exist on every single sterile glove in your hospital, every single mask. You know, these things are everywhere. And if you start paying attention, you'll see how so many of our plastics are sterilized this way. So we're not measuring that, and we need to push for starting measuring this stuff. You know, we take care to measure the data on how much X-ray radiation we're all being exposed to, but we're not taking care to look at these other things and what is that impact. Just because we don't measure it doesn't mean it's not there. So the kind of way I would look at this from a practical perspective is demand healthier, cost-efficient options from our suppliers, and then industry will move to make these gains. We know that the alternatives are there. They're just not there on the scale that we need. Some of them are easier, some of them are harder to implement, but they exist. And finally, I wanted to just have a quick comment about things like surgery packs. Like Medline will you know, we order the surgery packs from a place like Medline. Medline gives us these packs. They're pre-sterilized. They're ready to go. I do interventional pain, and we just chose our packs recently, right? So my thought is this: if we know that this pack minus this 1 5cc syringe is great to be sterilized outside of ethylene oxide, you know, we can bring this information to administrators or department chairs or whoever it is in your organization who's making the decision on what surgery pack is being used, and say, hey, well, there's this alternative. We can buy everything from this pack minus this one issue if we, you know, want to reduce risk. And it is partly just a matter of awareness. You know, a year ago, like a year and 3 months ago, I'm a physician working full-time, living 2 miles away from this company. I had no idea what ethylene oxide was. So most of our physicians aren't going to know, and we just need to increase awareness so that they can make choices that are reasonable. And I think same thing goes for hospital administrators and staff. So, you know, this is something that we're all on, hopefully going to see a huge change in history, and that's going to be really, really impactful, kind of similar to what it was like when the awareness on tobacco became so prevalent in our country. So, you know, you're doing the good work. It's hard work, but we all need to be together on this. So that is all I have.
Well, thank you both very much. It was very interesting to learn about ethylene oxide. It has been a topic of interest in the news and with its impacts to the healthcare supply chain for sure. So we now have the opportunity to ask a few questions. If you haven't already, please type your questions into the Q&A box, which you can open by hovering your mouse over the ellipses icon at the bottom of the WebEx browser and clicking Q&A. And we do have one question, and that is, what additional sources are there to learn more about alternatives to ethylene oxide?
The FDA website is really the excellent one with this and this panel meeting on this. Additionally, AMI, A-A-M-I, is the Association for the sterilizing professionals for the health sector. It has a 275-page technical manual that is purchasable that will give you the alternatives and the pluses and minuses, as you saw on the slide that Dr. Shahbandar showed. Finally, ISO on an international level, International Standards Organization, has some alternatives as well. These all duplicate each other, so I don't think you have to go after all of them.
And I would just add that I am going to distill the information from that FDA presentation. There are a bunch of different companies that provide the alternatives, so we will be handing out a form in the next week with kind of what company does what kind of sterilization technique to make it a little bit simpler for people who are looking at alternatives.
Thank you. We had another question regarding current supplies for our patients and some of the issues that have come about with the ethylene oxide awareness. But what is the FDA doing now to help ease the burden on our hospitals?
Well, I'll take that one again. If you go to the FDA webpage, you go to FDA and ethylene oxide. They describe well their concerns here, what they're following up, their early warning system, etc. They have identified a couple of areas of concern, but they have not identified any particular shortages, though some of this may be from shipping from one area of the country to the other. Under Prop 65 in California, there's really no industrial sterilants, as I understand it, so they have to come in from outside the state anyway. But this may add to the costs, not the availability.
Thank you. And that kind of leads to the next question here. In terms of cost, how do the other newer options compare to ethylene oxide?
I don't know the answer to that. I think some of the older ones, radiation, E-beam, those ones are probably closer to ready to do things at a larger scale level, and costs then, of course, are more reasonable. I think as we shift from small use of hydrogen peroxide to larger, same thing goes for this peracetic acid, the price will go down there, and then as far as I can understand, it seems like chlorine dioxide is the closest to, with just a few changes, being able to plug and play at probably not such differential in cost, but I'm not sure about that.
And just to bring in the social dynamic for a moment, as we always talk about in the environment issue, it depends if you add in the externalities, the external costs. Clearly, the external costs of 100 times increase in breast cancer from this exposure, if you brought in those costs, the alternatives would pale in relationship.
Well, Dr. Shahbandar and Dr. Orris, thank you very much for such a stimulating discussion of ethylene oxide and the awareness around this topic. We really do greatly appreciate what you've shared with us. And thank you, everyone, for participating today. If you have additional questions, please email arm@aha.org, and please let us know what you think of the presentation session by completing the survey. We hope you all have a great day.